Good morning everybody and welcome to the Health and Adult Social Care Scrutiny panel this morning. The first item on the agenda is minutes of previous meeting. Do we approve the minutes of the previous meeting? Yes. Are there any points anybody wishes to raise from those minutes at this moment in time? No? Okay. Do we have any apologies for absence? No? Anybody need to declare any interests? Yeah.
I just need to declare that I'm a volunteer with Health Watch and also that I am a carer rep with mental health services with a service user insight. I do this on a voluntary basis, attending meetings and sitting on steering groups. Thank you. Anybody else needs to? Right, thank you. All items on the agenda are to be taken in public, and we welcome a representative from Health Watch here today. Item 4 then is the integration of health and adult social care, and we've got representatives from the CCGs and the council here. Is one of you going to do a brief introduction, bearing in mind that we will have read the report? Okay, before we move into questions. And do you want to say who you are before you start? Thank you.
Good morning, I'm Helen Sevens. I'm Service Director for Integrated Commissioning for North Kirklees CCG, Greater Huddersfield CCG and Kirklees Council. So it's a joint post. So bearing in mind you have read the report, this is an update of where we are on the integration plans and journey that we are taking to bring together health and adult social care across Kirklees as a place base. So the report outlines the work we're doing along the West Yorkshire and Harrogate Health and Care Partnership. It identifies the work plan for the West Yorkshire and Harrogate Joint Committee of CCGs, where we're coming together as 11 CCGs across that footprint to work on things that are best done on a larger population basis. Excuse me. I might have to hand over to Steve in a minute. 3 is then the link to the Kirklees Health and Wellbeing Plan, and this was endorsed by the Health and Wellbeing Board in September of this year and is now on its governance route through all the partnership boards for their support and then implementation. The Kirklees Health and Wellbeing Board in September also agreed an integrated commissioning strategy, and that's about how we will develop and implement that health and wellbeing plan. So the specific items of the Health and Wellbeing Plan include creating communities, starting well, living well and ageing well. It's about how we develop integrated person-centred care, especially for the people with most complex needs. It talks about how we're going to work on populations of 30 to 50,000 and how we're going to develop primary care networks, working around individuals in those communities, on providers coming together to provide holistic care to those individuals. There is then some key areas around key priorities. One of those is intermediate care and reablement, which is a joint project across Kirklees with the Council, Social Care and all providers. We're doing some specific work around care homes and around a new model of end-of-life care. And last week we were asked to speak at the Hospice UK conference in Telford about the innovations that we're doing around both commissioning and providing of end-of-life care. How we're going to develop and support our workforce and to make them more resilient and to develop new models of care. How we're going to support our communities, because obviously communities and community capacity is the bedrock of what we're trying to do across Kirklees. How we will harness digital solution and what the digital journey is going to help and support those developments, and also how we're using the Better Care Fund to take these developments forward. It also identifies in the paper the Integrated Commissioning Board and the Health and Care Exec, which for the first time in Kirklees has brought together the chief executives of the council, the CCG and the provider health organisations to ensure that we're taking this agenda forward. So in support of that and in the governance framework, there's also the development of an integrated provider board, and that is also the first time across Kirklees that all providers, including the voluntary sector, care home representatives, and we're hoping to get a domiciliary care provider representative there, to look at how the providers will respond to developing those services on an alliance model of care. Thank you.
Okay then, so we'll open it up to questions then,
Thank you. Good to hear, first of all, that your post is integrated across the 3 organisations. That sounds really good. Question really about the primary care networks. Could you say a little bit about what status they have? And will they have some kind of legal structure, or are they basically a form of collaboration? How will the primary care networks link in with Lacala and Lacala's locality structures? And also there's a reference in paragraph 151 to the England maturity matrix. Could you say a little bit about what that is? Thank you.
So I'm going to ask my colleague Catherine Wormston, who is Head of Primary Care for both CCGs, to come in and answer those questions. Press mine off.
Good morning. Thank you for inviting us along today. It's really good to talk to you about the journey that we're on towards more integrated services for patients. So specifically around primary care networks, I think we've had groups of GP practices working together over a number of years, but I think what we're asking them to consider now is quite different, whereas before practices have been thinking really about their own general practice business, how they're going to cope with the increasing demand, how they're going to manage an ageing population, how they're going to try and recruit and attract a sustainable clinical workforce. So I think what we're trying to encourage them to think about now is that the only way they're going to manage that is to be integrated on a more wide footprint with people like Lacala, with adult social care, with mental health services, so that we're really at the start of that journey, and the maturity matrix that you mentioned is just basically that. It's a grid that describes the journey and some of the milestones that we might see these primary care networks looking to aspire to, so that we get towards a fully integrated service. So what we're trying to do with our local GP practices is make sure that we've got the right geographical alignment. So you'll see from the report that we've got 9 of those primary care networks earmarked now across Kirklees, so 5 of those on the Greater Huddersfield side and 4 on the North Kirklees side. And I think what I'd probably emphasise is that our partners, Locala, local authority, the hospice, are really, really keen to work with us in this way. GP practices, as you might know, are independent businesses, and sometimes they've all got quite different views and they've got different aspiration for what pace they might work at. So it's quite an ask to get everybody to move along at the same sort of pace with the same goal, and that's something that we're working very hard with our practices to encourage. But you know, our partners are more than up for this journey and are very keen to work with us. We've got some sort of pilot areas where these conversations have already started, and there's some real good work happening out in the valleys, out towards Home Firth, where these conversations have already started to take shape and to look at how we can actually get the best for patients by delivering services in a more integrated way.
Thank you. Just in terms of the organisational structure, will the networks have some sort of legal status, or are they effectively a collaboration between a number of different organisations? And will they employ any staff?
Yes, it's a collaboration, and I think we've taken great pains at this stage to emphasise to GPs that it doesn't affect their contractual status or their independent contractor status, but there's an awful lot that they can do just by working together and building those relationships and building trust. So at this stage, they don't have a legal status, they don't have bank accounts as a collective or anything like that. However, further down the line, and what you've seen in other areas of the country, is that some practices, when they do work together, realise some benefits, and that might result in practice mergers, or it might result in looking at different opportunities and different contract vehicles to remove some of the bureaucracy and get some efficiencies of scale.
Hello, I'm Alison Monroe, and I'd just like to ask a question. How will the primary care networks fit in with Community Plus, and how will that work? How do you envisage that will work? Thank you.
Hi, so I'm Steve Brennan. I'm the SRO for Integration and Working Together, and a bit like Helen, I'm in a shared role across the CCGs and the local authority. So in terms of how Community Plus fits into this, I suppose there's two ways in which it fits in. One, it's absolutely part of the vision for where we want primary care networks and that wider integration of services to go, because that's the bit that begins to integrate us into communities. So not just the integration of formal service providers, but how we begin to work with communities in each of those areas to develop their own resilience and to provide the kind of support and services they need to help them do that. The other bit as well is Jill Greenfield is working very closely with us on this. So as she's developing how Community Plus works and goes forward, she's already beginning conversations with some of the primary care networks about making those links. So again, not to overemphasise the valleys, but in the valleys where those conversations are a bit more advanced, those conversations are beginning now. So the way we see this working is the various services that are already focused around delivering with communities and the slightly different geographies that they work on could get really complicated if it was a conversation about geographies. But if we can help people just get to know each other and make contact, that becomes much more simple. So Communities Plus is very much part of the vision for what we want to deliver, and we're just making the practical links so that that's built into how this develops going forward.
All right, thank you. You did mention how you can help communities develop resilience. Can you tell me what you mean? What does resilience mean? Thank you.
So I'll get this wrong because I don't use all the right language, if that makes sense. But resilience in that context is the bit about how do you, as well as having a really good medical model, so where people need formal services, whether that be healthcare or social care, the way in which those services are delivered needs to be done as best as we can. But I think there's a growing realisation that that's doing things to people, which sometimes needs to happen. But the resilience bit is about how do we help communities become stronger? How do we help individuals within those communities live a good life? How do we get alongside the communities so we go to where they are and understand what they need and how we can best support that and help encourage them to do that themselves rather than putting more and more formal services in place? So things like the local area coordinators who are just beginning to come into post now, that's a crucial way in which they work. So it's that real bit about getting alongside individuals and communities, understanding what they need, and then helping them do as much of that for themselves and others as they can, rather than sort of giving them a formal service to go and work with. So it's very much that side of things. And there's a number of practical things you can do to help do that, rather than it just being nice words, if that makes sense.
Thank you. I'd just like to ask a further question, actually, because I'm just wondering how are you going to bring the communities together to work with them so that they all know about what you're doing and what your plans are? Thank you.
So again, I think a lot of that is about recognising that sometimes when people like me talk about communities, we do that in a way which would imply that they're not already there, and actually these communities are there, and people who live in the communities recognise what that means to them. I think at the moment we see Community Plus because that is much closer to the communities potentially than some of the bigger formal services. That provides a bridge. So because they're about getting into the communities and understanding what's going on, and they've already got a lot of established links with the communities, if we can then link Community Plus in with the emerging primary care networks, we kind of pull in all those links through, if that makes sense. And the bit about going forward, how do we engage with communities about how the primary care networks work, that needs to be in the bit when, and they're not quite there yet, but that needs to be in the bit when they're thinking about how they might actually deliver things in the areas. So it's not a theoretical engagement process about a picture on a piece of paper that tries to describe what a primary care network is. It's more about, do you know what do we need in our area? What are the gaps? What haven't we got? And how might we begin to fill some of those gaps? And again, I think that's where Community Plus and the local area coordinators can play a crucial role, because it's about using that, not people like me sitting in a room trying to work out what I think somebody might need.
I'd just like to ask, obviously, lots of people work, and I go to lots of community events, community associations, and there's never more than a handful of people at them. So when you're reaching out to the community, I think it's going to, from my experience and from having been to community association groups and knowing how they all operate and how they all work, and it's always a handful of people who are actually involved at the end of the day. I think in practice this is going, I can just see that it's, because a lot of people do work and they haven't got time. I think it's going to be very difficult. Obviously it's your problem, but it's going to be extremely difficult to put into practice, I think. But thank you.
Can I just come in on the Community Plus? Because I think you are saying that Community Plus is working in communities and getting to know communities, etc. But as Scrutiny, I think we've yet to see that evidence that actually that is happening. Certainly, this Scrutiny Committee has asked before that Community Plus talk to local councillors about their local communities, and I think we've yet to actually see that happen as fully as we would like. You are talking about, in your report, you're talking about them changing to a stronger place-based outreach approach, identifying staff to wards. Now, I'm presuming that's local authority wards and not hospital wards, but there you go. And neighbourhoods, and people with lived experience to undertake volunteering. What does that mean? And stay and play sessions. Well, the children's centres certainly used to do stay and play sessions. So where is that coordination? And then he's saying Community Plus delivery will align to the primary care networks. Well, Community Plus have moved into 4 localities in Kirklees, haven't they? So they're going to realign from the 4 localities to the primary care networks, or are they going to work in those 4 localities and split themselves across the primary care networks? It is not clear, but your basic premise that Community Plus is well established in communities and knows about communities is the questionable thing that we have, in that we're not seeing evidence that that is actually happening. And you've not, when we've talked about Community Plus, that has not been evident in the reports that we've had as Scrutiny. Hamid, did you want to come in on this particular one before I bring you back?
Thank you. Some of those points have been raised by Councillor Munro and Councillor Smage, but again, Community Plus, I've seen very little evidence of them delivering anything in my community. Now, some of the things that you mentioned is like reinventing that model, like Liz has said, in terms of stay and play. Those sessions have been tried and tested, so you seem to be going backwards rather than coming up with innovative ideas of how you're going to be engaging with these communities. And some of these communities, they're very difficult to reach. Now, if you don't have the capacity or the resource to actually engage with them, what is your sustainable plan going to be? We can't keep on going backwards and thinking, well, this is something we're wanting to try again, and this is a new idea, because it's not a new idea. Coming from an engagement background, I know that these have been developed and delivered in the past. So what is new about Community Plus that you're thinking that you're going to be delivering, and you're going to be having a wow factor with these communities, and sort of overturning the mental and health and well-being of some of these communities?
Okay, so I'll start, and then I think Phil wants to add something to what I'm going to say. So Community Plus in depth is not my area of expertise, but clearly I do work with Jill on this. Apologies if I gave you the impression that I thought this was all 100% fit for purpose and good to go, because that wasn't what I was trying to do. I think we recognise that this is not easy, and actually there's much more we can do in a lot of these things. One of the things we are wrestling with at the minute is a lot of what we're talking about is developing at the same time. So whilst Community Plus is developing and trying to do what it needs to do, we're trying to get the primary care networks up and running and try and get them doing what they're trying to do. And because a lot of these things are moving at the same time, that's just what some of the complexity that we're trying to wrestle with. I think what we're doing around, and I potentially use Community Plus as a bit of a shorthand for what we were trying to do, We are conscious that many of the things we're trying to do are not necessarily new. I think what we're trying to do differently going forward, though, is recognising that a lot of those things that we tried before were the right things to do. Maybe what we haven't always done, though, is stick with them for long enough. And what we certainly haven't done is stick with them for long enough and begin to make all the helpful links between other parts of the system, so that actually what they do is they coalesce into a much more solid way of working. So we do appreciate there's a lot to do. I will feed this back to people working in Community Plus as well. The other bit about the 4 Community Plus areas and the 9 primary care networks, that's one of these geographical things that where what we're also trying not to do is have a mapping debate about which geography is absolutely the right geography or the right footprint to deliver these services on. So it is much more, rather than Community Plus rearranging itself to work on 9 footprints, it's the 4 existing footprints making links with the primary care networks that are in the same areas as that, in much the same ways that we're going to be asking them to make those links, or they're wanting to make those links with the community hubs that grew out of schools as community hubs. So some of that sounds quite complicated when you do it on a map. When you look at the number of people who need to talk to each other, it's slightly less complicated, because it's about helping those people make those contacts.
I'm Phil. I work for the Council on the integration agenda more broadly. I think one of the critical things that we've also started trying to do is to make the connections to the other bits of the system. So there's a few things worth mentioning. The Council's been leading the country, I think, in terms of the work of the Democracy Commission. So part of what I'm trying to do is to make sure that a lot of what we're talking about is connected into the work of the Democracy Commission, which is trying to get to the same end point of enabling more people to be more active in the processes around whether that's formal democracy or trying to shape the way their community evolves. We're putting a huge amount of effort into making those connections, and when you start to unpack how many different people there are, it is a limited number, but I think historically they haven't connected up as well as they should. We've got patient participation groups in all GP practices, which I don't think have particularly connected in to what the Council was doing in the past, but we're starting to do that. We've got Health Watch, who are part of the formal system, and one of the things that we're talking about there is making sure that the work of Health Watch, I'm hoping Helen's going to nod in the background, the work of Health Watch is connected into the development of primary care networks, and that links into Community Plus. And just to pick up on something we've already mentioned about new roles like local area coordinators, because there's quite a bit in the report about the amount of finance in the Better Care Fund, which is a substantial amount of money, but the reality is there is less money available to support the sort of activity that we're talking about. So we're trying to make sure that all the things we are spending money on, we're getting the bang for our bucks and they're doing more than one thing. So we're piloting local area coordination with Better Care Fund money, and part of that is about actually working alongside individuals and their small social networks to say what is it that's going to help you realise your potential to do what you want to do and therefore not need formal services. And those services alongside things like social prescribing are all part of Community Plus now, and that's part of us trying to design in those feedback loops so people don't need to just go to a meeting. There will be meetings to go to, no doubt, but it is about connecting in with the people's direct experience of services. That issue of lived experience is perhaps a clumsy way of saying if we're trying to redesign things like the CAMS service and make that more sensitive to the needs of people who, young people who've got mental health issues, we need to work with those people very directly and their parents and their carers. So we've got good examples of people with mental health problems providing peer support. We've got people acting as peer advocates. So it's trying to use those sort of models rather than saying you need a professional worker from the council to talk to you about what your life's like and what we all might be able to do to improve it.
I appreciate you're not part of Community Plus, but your report gives an outline of that Community Plus is the basis on which your wellness model will work. your PCN, working with your PCNs and working in your communities and providing your capacity. That seems to be the sort of the base of what you need to do to progress. And I think what we're saying is we're not seeing evidence that that base is in place for you to progress. Now, I've got several people who are wanting to ask questions. What I need to know is, are they around the Community Plus or are they on another part of the report? I'll take questions on Community Plus and then we'll move on to the rest of the report. How many is yours on Community Plus?
My question is that when are we actually going to see this initiative in fruition? How long is it going to be? How long is it going to take before these area coordinators are going to be imposed and we're going to be actually seeing that communities are being engaged?
So the first 3 of the local area coordinators, I think, started this week. I think their first day was yesterday. I was at an event yesterday where we were beginning to talk about how do we do some of these things going forward, and they were there as part of their first week in post. So they are relatively new in, so clearly they haven't done anything yet, but they'll be working through that over the next few months. So as we go forward, that's when we would expect to see the impacts of this. But the first 3 of them started this week.
Surely there must be a timeline that you can give us. You know, because what I find particularly, you know, with some of these initiatives, we seem to be talking and talking and talking, and we're not seeing any delivery and no impact in those communities. And bearing in mind, you know, we're faced with massive cuts. You know, we can't be sitting around and thinking, well, okay, you know, we're still developing this initiative, you know, it's still in the process, it's still in the motion, and 12 months later we're still, you know, dragging our feet.
Again, understand the point that you've made. I wonder if what might be more beneficial is if we bring a more specific update on Community Plus to a future meeting, because we can explore those issues there with the people who are actually responsible for running the service, rather than me sort of acting as a bit of a go-between. So that might be more helpful for you, rather than me answering that question now and not doing it justice.
Helen, can you say where you're from first? It's the large button, okay. Okay.
I was going to say that was the thing that was terrifying me the most, was trying to work out how to use the microphone. So I'm Helen Hunter. I am the Chief Exec at Healthwatch Kirklees and Healthwatch Calderdale. I think perhaps what I want to start by saying is I've been attending the Kirklees Integrated Provider Board, and I think perhaps I should offer some support to the people who are presenting and say, actually, it does seem when I'm attending that board like there is progress that is being made, meeting on meeting. It does feel like it's developing and enhancing, but I think it's hard to convey the changes that are happening because it is quite organic. It's not about constraining the development, it's about sort of allowing it to happen. But I fully appreciate that results need to be seen. What I think the thing that's come forward for me through attending some of those meetings and listening today is that whilst I agree with kind of organic approach around the development of the primary care networks, I have some concerns about the potential of that widening some of the health inequalities in our local areas, and I imagine that is an issue that is being tussled with nationally as well. I guess perhaps I'm nervous about GP practices engaging with their population to understand what it is that is most valuable to the people that they are kind of representing when they're trying to enhance the local offer for people. And so I guess my question is about what's going to be in place to encourage each network to make sure that they are responding to the needs of their communities.
I think I've got similar anxiety with this microphone. Thank you for those comments, both the supportive ones and the questions that you've raised, because I think they're all very valid questions. I think certainly in terms of GP practices and them being focused on their patients and the population and the wider community. I think that's very much where we're trying to encourage them to start the conversation. So completely take your point about health inequalities, and whilst we don't think we'll ever get everybody focused on the same things, that might be the right thing. So I know when Steve's talked before, we've talked about, you know, potentially out in the valleys where it's a little bit more rural, there might be a lot of issues around isolation, social isolation, potential mental health issues. That's quite different from when we're thinking about the population of, you know, Dewsbury and some of the challenges that they've got. So those networks, we are trying to say, in the first instance, please be mindful of what your population needs. So they might not all be focusing on the same thing at the same time, but I also take your point in that there has to be some consistency, there has to be some governance, there has to be a mechanism for us to be able to hold the ring as such on all of that, so that we've still got a Kirklees picture. So we've got a programme manager working with us now on primary care networks who's proactively trying to put some of those building blocks in place, and I think we'll see some fairly rapid progress. And I'm pleased to hear what you were saying about integrated provider board, because I think there are obviously lots of questions around Community Plus, but certainly in terms of general practice, I've only been here myself since June, but you know, the conversations that we're having with them, they're all very stretched. The capacity is a challenge now. It's a challenge to recruit people. So a lot of the GPs quite quickly are seeing this as a way to be able to deliver services more effectively for patients. So I think we've got a long way to go. And I think at the point where patients start seeing a difference is going to be a little bit further down the line. But we would certainly be encouraging them. I think, as Phil said, they've all got patient reference groups. And even though all the work's going on around communities, we actively encourage our practices to be having those conversations with patients, because often they're the best advocates as well for when things might be changing, you know, taking a more active role in their own health and self-care agenda. So I think we've got a long way to go, but it feels like in the sort of short time I've been here that we're making a good start.
If I could pick up on something that earlier people referred to, and that's really to come back to the whole primary care arrangement, and really to ask how federations will run, and in particular how a GP is being incentivised, because we know Kenneth Clark said years ago that you only appeal to the altruism of many GPs through the medium of their wallet. Now, you know, where's the what's going to lure them into this?
Okay, thank you. That's another good question. And I think, you know, to some degree you're right, and it's been recognised that all CCGs and all general practices up and down the country are getting to grips with this agenda of sort of integrated ways of working. I think we have been fortunate in Kirklees and across West Yorkshire and Harrogate to be given some non-recurrent funding. So we've got £1 per head of population to be able to do some work this year to get the primary care networks up and running, really just to allow those frontline staff to step away from the service delivery, to give them time to think about how this might work. I've probably laboured the point a little bit too much. General practice is a really, really busy environment. More often than not, they're worrying about the winter pressures, how they're going to make sure that they're staffed for the following weeks. They don't often get a chance to step away and think, what should this look like in 5 years? So a lot of the money that we're using non-recurrently this year is around giving them the time to be able to make those plans, to have the conversations, even to get to know their neighbours. Because in some situations they're working with general practices who they might have had a fallout with 20 years ago, or they might not, they might have got a slightly different ethos. And so it's quite a lot for them to just come together and to think about, longer term, these are potentially sharing staff, sharing premises, lots and lots of logistical things to work through. So they've got to start building those relationships and that trust. So we're hoping some of that non-recurrent funding will appeal to that nature that you've mentioned and will allow them time to do that.
Thank you. And then just to come back to the question that Alison raised earlier about resilience. And I just wondered where it sits in the literature as a concept. And I wondered how measurable it is. Because one of the things that's of interest is how is all this going to work with regards to keeping people out of hospital. So where does it sit as a concept, please?
I think I'd struggle to give you direct references, but one of the things that comes out strongly, I think, of a lot of the things that Public Health England in particular have been producing over recent years has been the importance of trying to shift that relationship between people and the statutory services. And certainly when you look at things like the patient activation measure, which we're looking at using locally, it's clear that the people who score well on something like a patient activation measure, which is basically a measure of how much responsibility you feel you are able to take for your own health and well-being, there seems to be a direct correlation between people who've got high activation and their health status. I wouldn't want to get into a debate about correlation and causation right here, but our understanding from the broad evidence that's around is that the more we can support people to take more control over their health and the health and well-being of their family, the better it will be for them, and they will mean that the services, and this goes, I think, to the inequalities point, that the services that are available, which many, if not all of which, are stretched because there have been significant increases in demand and there haven't been the requisite increases in funding for all sorts of reasons. The more we can do to make sure that people who can take more responsibility for their own health are doing that, then the better able people who really need the support of professionals will be able to access that in a timely manner.
So resilience is, amongst other things, is a philosophical concept. It's a belief. So what about the unbelievers? You know.
I'm not sure I'd call them unbelievers, because one of the things we know from work we've done locally, based on the again something developed by Public Health England, is we know that across the population of Kirklees we've got a disproportionately large number of people who are very interested in their own health and taking a very active role in it, but at the same time we've got a disproportionately high number of people who are quite fatalistic about their own health and well-being. So if those are the non-believers, I think part of what we've done over the past few years is start to get an understanding of that and say that when it comes to designing how we work and how primary care networks work, we need to understand the difference between the people who don't feel like they've got any control and the people who do, and we need to orientate the way we provide services more towards the people who don't feel they've got any control, to support them to, in whatever ways we can, to feel as though they can take more control.
Yeah, I don't think we need worry about the worried well. I mean, they'll survive. It's the people who, who and I'm just wondering, whether the system could cope with them. And then the last thing, please, Liz, is that I wondered how you reconciled your 5 priorities in health and well-being with what Locala is doing in care closer to home, because somewhere along the line, whatever happens, we're going to lose acute beds, and it's going to necessitate, unless I'm mistaken, it's going to necessitate looking after far more acutely ill people at home. Now, when we asked Locala some time ago now about outcome measures from care closer to home, they didn't really know their own from their elbow. They couldn't tell us how many bed days it would save. They couldn't tell us how many A&E presentations it would prevent, and so on. What I wondered was, how does well-being, how does it resonate, or does it resonate with care closer to home, or have we torn care closer to home up?
An interesting question. I think when we developed the Care Closer to Home model and contract in the first place, I think we were clear on both Greater Huddersfield CCG and North Kirklees CCG that we expected the service model to actually prevent admissions and attendances and lengths of stay, and also ensure that people were returned home or their home of choice as quickly as possible afterwards, and that was the whole premise of Care Closer to Home. And within the specifications, we did have some metrics about the bed day savings we expected as part of that contract. Some of that has been achieved, and we have evidence of that, going back to meeting the challenge. It didn't achieve all the bed day savings we expected, but it contributed to a reduction in beds that did come out of Mid-Yorkshire. That same process of development will need to now happen across with Right Time, Right Care, Right Place. So I think that's evolving and developing, but there is a recognition that over time, taking in demographic growth, potentially there could be seen to be a further reduction, but we need to work that through, and it's early days and we haven't done that yet.
Yeah, I just wanted to ask about the overall focus of the report. So there's quite a lot about principles, quite a lot about overview, quite a lot about new initiatives that are beginning to happen. There's a reference to expenditure under the two elements of the Better Care Fund, and a breakdown of the budget there. Now, the focus on integration is not new. I mean, it's not new for, it's been going for ages, but the recent refocus on integration is not new either. So, I wonder if you could clarify what the achievement's been on the ground in relation to some of those areas of expenditure under the Better Care Fund, as it were, to demonstrate that the principles and the overview are actually being put into practice. So what's happened so far that's worked well, and maybe some areas where things haven't worked so well. The other question linked to that is the Better Care funding recurring, and if not, how will that expenditure be replaced in due course if that's necessary?
Can I answer those in reverse order? Because the answer to the second bit is more straightforward. So, in terms of the what's recurring, there have been 9, depends on how you count them, 9 or 10 separate announcements about additional funding over the past 2 years, all of which have been non-recurrent. So, a significant proportion of the Better Care Fund, particularly the improved Better Care Fund, is not recurrent money. So, in terms of the budget planning that we're doing, we are trying to work through that. The difficulty we've got with that is that all of the funding is for different periods of time, so different financial years. The furthest forward it goes is the end of 2020-21. Between now and then, the NHS will produce their long-term plan. I think that might be before Christmas. The expectation we've got from the advice we've been given nationally is that that will include a continuation Better Care Fund at least for the next year, but beyond that, we're not sure. The advice we've also been given, although I'll be slightly more surprised if this happens, to be honest, is that the funding, the green paper about the future funding of social care will be published before Christmas, because a significant proportion, I think, there's all sorts of ways to present the breakdown of the Better Care Fund, but a very large proportion of what's in the Better Care Fund is supporting the local system to provide adult social care for people. So that's partly because when it was first announced it wasn't new money, it was basically a rebadging of existing money. And since then, the only way the council's been able to actually maintain the level of service that it has is by using some of the non-recurrent money in the Improved Better Care Fund to actually pay for people to receive both domiciliary care and residential care. So I think, in short, the answer is very uncertain what the future funding arrangements will be. I would hope that if we come back sometime early in the new year, there will be a lot more clarity than there is now, but it is a significant risk to the system, that lack of clarity. In terms of things that we can point to and say, yes, they have made a difference. Going back to some of the points we've made already, I think local area coordination is something that we have started just. It's actually taken us more than 12 months to get to the point of actually starting that because of issues about actually recruiting people with the right skills. So one of the things we found in quite a number of the things we've been trying to do is that lining up the money is sometimes the easy bit because there's so much consensus about the sorts of things we should be doing. Finding the right people with the right skills to actually implement those is much more of a challenge. Because part of what we've read, the context for this is a lot of the workforce development that's gone over the past X number of years wasn't training people with the right sort of skills to be able to do these things. If we wanted just another district nurse doing what district nurses have always done, that wouldn't be too difficult. But we're talking about different sorts of people doing different sorts of things. So that has been a challenge for us. Just pick up on some specific examples where we have actually managed to make some progress in terms of carer support. When we started on this work a couple of years ago, basically the carer support that was available was there was what Great Huddersfield CCG commissioned, what North Kirklees CCG commissioned, and what the council commissioned, and they weren't particularly connected at all. And there's a single set of services that are jointly commissioned on behalf of all three organisations that are provided by the Carers Trust and other local providers. And that's really helped them both to increase the capacity of what they've got because we've put additional money into it, but also to make sure they weren't being pulled in different directions by different paymasters. Similarly for the aids to daily living, we've had a pool budget for the equipment service for a number of years. It predates the Better Care Fund. But what we've managed to do now is to make sure that the equipment people can get through the equipment service, the adaptations they can get through the council's accessible homes team, and the assistive technology support that they can get through the council, that's care phones and all sorts of other things, is actually part of a single process and a unified system, not actually three different things. So people are thinking, oh, do I need equipment? Do I need assistive technology? Do I need a ramp to my front door? All of that's brought together into one place and then working much more closely together. Final example in terms of quite specific things around mental health contracts. And Vicky, who's going to talk about the next one, might want to say a little bit about this. We're now in a position where, in terms of the support we're providing to the voluntary and community sector to actually provide contracted services for people with mental health issues, there's a single approach to that, and it's all three organisations speaking with one voice to say we really value what the voluntary and community sector does. We want to have one conversation with you and think about how we can support you better and back that up with actual money.
Sorry, just quickly. I appreciate those examples, but they're basically about structure and staffing. And my question is really about what has actually changed on the ground. Have there been improvements demonstrated on the ground? The other point was, from what you said about the funding, under the Better Care Fund, maybe another 2 years. Beyond that, maybe another year. But financially, it's very, very uncertain. So with the slow start in actually achieving things on the ground and the prospect of funding being questionable, at least, it's a very difficult situation we're looking at, isn't it?
Yes. Just to pick up the point about actual tangible things. One of the things that's been an emphasis for the Better Care Fund a lot, from a national point of view, over the past sort of 12, 18 months in particular, is about our performance as a system around enabling people to both stay out of hospital and, if they're in hospital, get out quickly. So there's very specific things that have been paid for and supported through the Better Care Fund that have made a significant difference. So there's relatively small things, but evidence-based. There's the Red Bag scheme, which is about actually making sure that when people are admitted to hospitals from a care home, they've got a bag that's got the right stuff in it, and that ranges from the medication record through to their teeth. That bag goes into hospital with them, and then when they're discharged, the bag goes back with them. And there's a lot of evidence from nationally to say that actually both improves the continuity of care, reduces length of stay, and improves discharge. So we've now got that up and running in every single, nearly every single care home. Similarly for things like there's online system now for actually understanding where the vacancies are in care homes, so when people are actually in hospital and need to move into a care home, it's a lot easier for the social workers and the discharge coordinators to know where they might be able to go and then work with them. There are examples that we're just implementing now about creating additional bed space in care homes to give people the breathing space to make the right decision for them. So rather than having to be discharged from hospital under pressure to move into a care home, which will probably be the place where people live for the rest of their lives in a hurry, they've actually got the space to take stock and make the right decision for them and their families. There's lots of other examples.
Can I suggest that when you come back with a Better Care Fund later in the year, which I'm sure you will be, well, you are, yeah. That's part of my recommendations, that you actually look at outcomes rather than that, and we have a more detailed on outcomes of Better Care Fund. Okay, yeah.
Yeah, you have alluded to sort of replacing the need for a medical professional with social contact under Communities Plus. I wonder if you've got any notion of what percentage of demand on current care services you can reduce in this way, and whether that's driven by what is going to happen to the budget, or whether it's a genuine idea about how many people currently access care who don't need to because they're isolated or whatever. And my second question is comes from point 172 here, where the report says we'll be taking inspiration from national models which have worked well, and we'll outline our vision for the future across partners and assess our ability to access capital to support this development. I'm just interested in what, seeing, you know, a national model which has worked well, what you're using there.
If I can start by responding to the question about loneliness and social contact. I'm not aware that it is possible to put an exact figure on the reduction in the number. It might be the reduction in the growth of the number of people who need support, because one of the things that we are dealing with that's a critical bit of the backdrop to this is the change in the age profile of the population, significant increases in the number of people, particularly over 75s, and all the evidence that has been around for ages suggests that they're both likely to be bigger users of all services, whether that's health or care services, and they're much more likely to feel lonely and isolated, particularly if they're widowed and living alone. So I'm not aware that any health economist has worked out the exact figures to say that if you reduce isolation by this percent, the number of people accessing GP appointments or needing formal social care services will reduce by this amount. So I don't think that number exists. If it does, it would be great if somebody could let us know. What we do know, though, is, again, it goes back to the correlation causation issue. People who feel like they've got good social contacts are much less likely to use formal services as much, and that goes for both social care and healthcare, and there's plenty of national evidence around that.
Thank you. Excuse me, thank you. Just referring again to 1.7.2, where it says our vision for the future is that our community assets will provide communities with a wide range of services and support, not just health and care interventions, but a wider range of community services to serve a much broader range of well-being and social connectedness needs. And one of my passions is emotional well-being, and so I would like to see, moving forward with this, that physical health needs and emotional well-being needs run parallel and at the same rate, and that the emotional well-being support isn't something that's thought about and tagged on afterwards. Because I think we would all agree that physical health and emotional well-being have equal status and underpin each other. And so what I would like to see next time, perhaps, is some practical examples of how we're going to achieve and maintain emotional well-being within communities, having regard to a person-centred approach and diversity and cultural needs, because I think that is really important. And what we're looking at are social activities that can reduce isolation and loneliness. And yes, I agree that the voluntary sector have a huge part to play in that, but it has to be properly managed. People have to be recruited through a formal process, and we have to ensure that people aren't put in a position where risks arise, both for the person providing the support and those receiving it.
So can you bring practical examples back? Yeah, but can we unpack this vision for the future in 1.7.2 just a little bit? In that one of the things that it says is we will establish a Kirklees forum to review our collective assets, agree a future vision and a plan to deliver this. This sounds like reorganisation. It's linked with estates in the paragraph before. What exactly is it that you're meaning by this? Because one of the things that we've just gone through as well is libraries, and libraries' input into this, and them being more involved in this. This looks like, again, you're looking at the collective assets again and agreeing a future vision and planning to deliver. So are we going backwards again, or where are you starting from? What are you doing? How are you going to put in the broader range of wellbeing and social connectedness needs using community assets? I think, because you didn't quite answer, I don't think, the question.
Where is that national model?
Yeah, and where's the national model? I know I cut you off, but can you sort of unpack that a little bit for us? And we are, if you could do it succinctly, that would be really good, because we are pushing for time on this item. Okay, thank you.
So this is very much about the physical assets we've got, and in terms of what is going on, the first step, and it might be quite surprising that we haven't had this for quite a while, but we haven't, is actually making sure that we're clear about what all the assets, as in physical buildings, assets there are across the whole of Kirklees. So we've got people in the council's assets team working with colleagues in the hospitals, working with the people who've got access to that information about primary care and other partners to make sure we're clear about what assets there are. And the libraries issues are perhaps a good example. If you go to other places, they've made more progress than we have so far in terms of actually thinking about how to connect up the sorts of activities that go on in libraries with what's going on in primary care, with what voluntary and community sector organisations are doing locally, what people are interested in employment support are doing locally. So the forum, I think, is just about making sure that the people who are trying to work out what to do with the significant public assets that there are across the district, and when you look at the map, there are a huge number of publicly owned assets. The forum's about bringing those people together and saying, what are our intentions, aspirations for this particular area? But it's not about them deciding what that is. It's about saying, talking to the primary care network, talking to the major service providers, talking to the council, talking to the councillors, talking to the local community. What's our aspiration for this place? And then how can the assets best serve that, and thinking about that together rather than individual organisations saying we need to either keep or dispose of an asset because that's what's in our individual organisation plan for those assets. So, sorry, the national model, that's just about, I think it's a reference to places like Bromley by Bow is one of the best examples, and they've been at it for a long time, where they've actually come up with basically a very different way of thinking about what a health centre is. And it is actually something that I think lots of us would walk into and say, actually, this is what lots more places should be like, because they are focused on that balance between mental and physical well-being. They are about the community being right at the heart of that and shaping what that is, rather than it being something that's what a particular GP's aspirations might be for the building that he owns and controls.
Can you just give maybe a straight answer to a straight question? We've had an asset review already in the council. I understand this is working with partners now, but do I take it that this is an asset review again to look at whether assets are needed or not?
I think it's about making sure that when somebody says, if we go back to the valleys, when we go back to the discussion about the valleys and the development of the primary care network, it's when all the partners are coming together in that sort of environment, saying it would be great if we could find space together to do things differently, then we've got an answer to the question, okay, so what space have we already got, and what are our existing intentions for that space, and does that need to change?
Okay, can you get straight? Alison,
sorry, I'd just like to ask a question. It's in relation to assets. It's about whether you considered each specific asset in an area and its value and how it's valued by the local people who may be volunteers who are running that asset already, and whether you factored that into the equation, because what obviously adult health and social care is of paramount importance, but also it's not just about adult health and social care in a community. It's about the people who live there who may need services for adult health and social care, but there may just be people who just who work, who are part of the community as well, and whether you're considering everybody who lives in a community and how they relate to those specific assets.
We're still involved in the first stage of this work, which is actually about trying to understand the publicly owned assets. So therefore it wouldn't include any care home that's not owned by the council at this stage. It wouldn't include the community centre that's not owned by the council, with the minor exception of those ones that the council has asset transferred over to a community organisation. And certainly from talking to the colleagues in the council who are doing that work, that in itself is a huge undertaking, because it hasn't been done before, but it is the first stage. So there is an aspiration to do more work once we've got to the stage of being able to answer the questions: what publicly owned assets are there in the valleys, and what are our aspirations for those, and how do those fit with what the primary care network want to do, what the individual organisations want to do, to then build on that and say we need to understand community-owned assets, and also those assets that might be privately owned that are of significant value to the local community, and that might be the pub.
So in all of this, then, you need to be talking to people who understand the community, and we get back to the first questions that we had on coordination with elected members as well. Can we just, I'm going to bring this to a close, but can we just have a brief answer to the complexities of this, please? Because you've got a Kirklees Health Partnership Board, you've got a commissioning board, you've got a provider board, you've got the Health and Wellbeing Board. You've then, I noticed under end-of-life care, you've got strategic end-of-life commissioning, end-of-life provider, and the end-of-life strategy group. And you're also putting in another single point of access. So, yes, yeah, under the Kirklees Independent Living Team, KILT, there's a single point of access going in there. So there's complexities in governance and how they all link together, and complexities in also referring people into systems. And how do people know whether you're wanting to self-refer into something, if it is self-referable, or whether it's health and social care professionals that need to refer into places. How do they know which single point of access to go into? And how do you link everybody together when you've got so many layers of complexity in this?
So I'll have a go at answering the first bit of that question, which was about the governance and how do we do all of that kind of stuff. So you're right, we've got an integrated provider board, we've got an integrated commissioning board, and we've got the health and social care executive. There are people who sit on all three of those meetings, and that's an absolute deliberate thing to make sure that they're consistent and all moving in the same direction. One of the things we're doing at the moment is, having recently signed off the health and wellbeing plan, we are making strenuous efforts that each of those three bodies, groups of people, whatever you want to call them, own and understand the health and wellbeing plan and what their contribution is towards delivering that. Now, I'm not saying we've never tried to do that previously, but in my experience, this is a much more of a joint ownership of it, so less of a trying to sell the plan to people, and more of actually, because we engaged all of those people in developing the plan, we're beginning to recognise it as a joint plan. We're also working really hard to make sure, as the economic strategy is refreshed, that those two things are done very much in conjunction with each other, and that they absolutely talk to each other and help support each other. In terms of the complexity and what we're trying to do in terms of reorganising how the system delivers care and then the complexities of the care itself, we also recognise that this is not a top-down structural reorganisation. And if this is going to work, this has to come bottom up as well. And some of the things, these aren't the only things, but some of the things we need to address in terms of doing that is the people who work in, and I'll list organisations, if I miss somebody off, it's not because they aren't important, GP practices, locale, the provider of community services, the mental health trust, the acute trusts, social care, the voluntary sector. There's a huge number of individuals who work in that sector. We are working on an OD plan at the minute that will begin to kick in February, that won't touch, all of those individuals, but we're hoping we can touch enough of them that we spread the message amongst professionals and individuals out there who are delivering care. So as well as us saying at the high level, this is a direction we want to go in, the OD plan is helping people make those new relationships, develop new ways of working with individuals, and beginning to empower them to do the things that, if we're being honest, they already know needs to happen. It's just that the system doesn't particularly help them do that. So that's another thing we're trying to do. And then one last thing, because I appreciate we're tight on time, in terms of how we do the more formal workforce planning to support all of this. We do now have an integrated workforce planning group. I think that is the first time we've had one of those for Kirklees. It's only met 3 times, but I think we're getting to the point now of understanding what that role might be in terms of developing a workforce that is more flexible, more suitably qualified for what we need to happen going forward. Doesn't think necessarily about professional or organisational lines, but thinks much more about what the care is that needs to be delivered for individuals. We are trying to link that also into the economic strategy, so rather than having a load of disparate initiatives down here, there are clear links about how that supports the health and wellbeing plan, the move towards more integrated care and primary care networks, and can support some of the things that will be in the new economic strategy about making the health and care sector an attractive place to work, so we can recruit people into it. They've got pathways, they are skilled up for what we need in the future, not trained on traditional lines that maybe more suited a previous way of working. So there's a lot of stuff there that we're trying to do to not constrain the complexity, because you can't, but push on all fronts, and where we can align things, absolutely making sure they're aligned.
Just you seem to have multidisciplinary teams working in one area, multidisciplinary teams working in another area, multidisciplinary teams working in a third area, and they're all the same skills that in the teams, and it does sound extremely complex. Having commissioning board and provider boards, and then having other commissioner and provider boards underneath that, how you're actually going to link all that together. And I think maybe we'd want to see some practical examples of the outcomes that can provide for people, in how the complexities of that governance actually provides outcomes for people at the end of the day, and how people, because it does sound extremely complicated now, it really does. But I'm going to bring this to a close then. So I think we've touched on health inequalities and a greater emphasis on health inequalities, and ensuring that is a thread through everything that you're doing. The care closer to home and the impact that's had. I know you'll be coming back to scrutiny with that, so we need that. The outcomes of the Better Care Fund, we'd want to know more about that when you come back with the Better Care Fund, and we'll talk to you about that. And the practical examples of how your different levels of complexity are actually making a difference for people, and also your single points of access. How on earth do people know which single points of access to go into? It really does. And your Community Plus, we need to see far more evidence on how that is working, and we request again that Community Plus talk to local elected members in their wards. We make that request yet again. Have I missed anything off that? Oh yes, the GP federations, we want to know how they're working together as well. Okay, all right, we got all that. Yeah, okay, thank you very much, and we'll move on to the next item. We'll just pause a minute while we move on to the next item. Thank you. The next item, which is the Kirklees Mental Health Rehabilitation and Recovery Services. This is the report from the engagement that has been undertaken that were previously discussed, and it is for the panel to see whether they are content with the engagement, and you will be bringing back a proposed model later in the year. So do you want to introduce it first, and then bearing in mind that we'll have read the report, and then we'll go on to questions. Okay, thank you.
Hi, I'm Vicky Dutchburn. I'm Head of Strategic Planning, Performance and Delivery for the CCGs.
And I'm Dawn Pearson. I'm the Engagement Lead for the CCG.
So we came a few months ago, I can't remember exactly when it was now, because we've been a few times about this, and we gave you a brief picture, or quite a detailed picture, of some of the identified changes that we believe need to be made to our current rehabilitation services for mental health service users. And at that time, we came to talk to you about us embarking on an engagement exercise to start to put some meat on the bones so that we could start to develop this. We agreed we'd share back the report with you, and you've asked us to come and present, well, not present it necessarily, but to discuss it with you, specifically the things that we said we'd want to discuss, but if you thought we'd got any gaps in the engagement that we'd undertaken, so that we could build on that going forward. And we also said if we thought we'd identified any, we would share those with you. The other bit that I'd just like to say about well, not the report, but the background now, is some recent direction from NHS England and the government about rehab services for people with mental health issues is changing. So there's a big piece going on across all the country, but regionally, at regional levels, looking at the number of patients that are in out-of-area placements for long-term rehab packages. So us starting this piece of work last year and starting the engagement has actually put us on the front foot of that piece of work, and what we are finding following discussions is NHS England are going to be expecting every region to start doing some engagement, so that they can start to look at what the whole service of rehab needs to look like, from very specialised that will be done probably on regional footprints and commissioned for populations because it'll be small numbers but quite costly, down to what we deliver locally. So for that, we're certainly ahead of the game, thankfully now, because we have done the work on understanding our numbers. We know what we've already got. We've started the engagement, as you're going to see. So I just wanted to put it into a little bit of context, because you'll see that in the press coming forward.
Okay, all right, I'll open it up for questions then. Peter.
I just wondered, please, how you'd got on with your user group. I think one of the things we raised in July when you came was that, and you say in your terms of reference, that these people have got a primary diagnosis of psychosis, and psychotic people are often not the easiest to get a story out of, and they're not good self-advocates, unless I've misread it. And I just wondered, A, how you'd, what you'd made of the data and how reliable you thought it was. And secondly, something that I must have overlooked. You say in your methodology that you used 3 approaches: surveys, I think focus groups, and then you said commissioned artwork, and I just wondered what that was.
On the front, so we'll...
Okay, so in answer to your first question, the best approach we thought for reaching people who are already in services was to use an advocacy service. So we commissioned Touchstone Advocacy to involve those people because they've got that skill. They're known to service users, and they went into the areas that they already work with and have relationships with people in. It was a challenge. The feedback coming back, it's limited in the information we were getting. So it's always a challenge trying to get feedback from individuals who were in those situations. But I think Touchstone did everything they could do using their advocacy skills to support that. So we were really pleased that we were able to use them to facilitate those conversations. For the out of area, we used the providers themselves because there is a range of people across different localities. So they used in-house teams to support conversations with service users, and they came back through to us. Can I just ask you what the second question was? Oh, yes, okay. So a colleague of ours who's quite new to the team's really creative, and she wanted to do a piece of artwork. She's got a background in mental health, and she felt it would be good to get people to demonstrate through an image about what good accommodation would look like. So the artwork on the front, we've got a great big board in our office, and it's got illustrations on. They've almost designed the building, but it's got beautiful quotes on things that they want. And what really came out of that was how much people wanted to feel like an environment that's calm, like home, but particularly that has family and friends within it that can be in it, and not a clinical environment. That was really important to people. That came through really strongly through the image of the picture.
Thank you. And with regards to the success of the service when it's up and running, do you anticipate more people will be able to live independently as a result of?
Yes, so the whole ethos that we're going to be doing this work around is to help people and support them to be in the least restrictive environment based on their needs. So the aim the fundamental aim is that less people will need to be in locked facilities or even hospital facilities if it's the right thing for them, that they're there for the shortest amount of time. But at that point, we're planning for where they will go, whether it's back to their own home if that's where they want to go, or if it's to support them to get their own tenancy into a group home. So it will be back into some form of community, the least restrictive we can do.
Yes, morning. I found the particularly interesting part of the report was the reports of the focus groups, a range of different organisations, and some of the specific comments within that. So a couple of them were about, so this is on page 96 onwards, a couple of them were about accommodation, and on the St Anne's one it was saying that many people felt there's a need for smaller units to provide supported accommodation in the local community where people have the independence but 24-hour support and monitoring is available when needed. And one that reflected that also from the Hadawi Centre, a range of housing accommodation support in the right place, including floating support, is required to meet individual needs. Also longer-term tenancies and residential support for those with complex needs. So very sort of clear expressions there, I think, of the importance of a range of different types of accommodation. And I think maybe one of the problems at the moment is that because of the pressure on all sorts of budgets, the danger is that that range of accommodation, meeting those different needs, will shrink. So that's perhaps something to take into account. Yeah, and I'll come back on another point, yeah.
So, yes, so we've recognised as well, and this just reinforced our own thinking, that people do need a complete range of completely different offers available, and some of this will even go down to domiciliary care in people's own homes, etc. The principle that we're working on, we've mapped where everybody currently is in the service, so we know exactly what we're spending, whether it's in area or out of area, on all the ranges of facilities that fit the rehab label at the present time. And our intention is that we will start redesigning with that financial envelope. It's not about cutting that resource, it's about using what we've got to the best of our ability. If, as we develop and move on, A, we find there's gaps that need investment, we will be putting business cases together for further investment. But B, it might be that we get better efficiencies out, and there might be some savings to be made. And the agreement that we've got with the Director of Finance, certainly in the CCG, is that there can then be a discussion about where there are other gaps in mental health services to reutilise that money. It isn't that it'll be taken off the bottom line, if that makes sense.
Yes, I wasn't implying there'd be a cut necessarily in the budget around rehabilitation. It's the cuts to other parts of services, which then may have an additional impact on specifically the rehab service, because you may not be able to move people on because those facilities won't be there. Assuming that's the aim, that people would, some people at least, in due course would move on.
Yeah, but within our model we are looking at it on the whole spectrum, so we are looking at what is needed in the ways of floating support teams with that specific skill set, what is needed in community teams. We're doing work, I think I heard Phil mention that we're just re-tendering the mental health third sector contracts that sit within the BCF, which do a lot of the support services. So in total there's 7 of those that are just going through, that are actually being evaluated last week and this week as I speak. We're also doing very close work with the local authority and other partners, looking at other services upstream, so some services that might support people who are approaching crisis, so looking at developing a crisis cafe safe space type model collaboratively, looking at peer support within that. So it's about the continuum that people will flow but be able to access as part of a rehab model, but equally other people at other parts of the service will be able to use some of those as well.
Okay, and the other sort of aspect arising from these reports on the focus groups is first of all that the services that are talked about are there, I mean, they wouldn't necessarily permanently, but over a long period of time. So on the St Anne's feedback, a number of people said it was great, and they've been attending for 16 years. So not a pilot, not something that's a couple of years and then it goes. It's something they can rely on. And part of the feedback from Platform 1 was talking about the service being very approachable. So it's that kind of combination of something which people can rely on because they know it's going to be there, and secondly, they feel at home when they're there. Is a very approachable service. I think those are 2 kind of key bits of the feedback to feed into the next steps.
Hello, I'm Alison Monroe. I just want to ask, I just noted that in the engagement in the survey that many of the questions, four of the questions are directly aimed about about the community and what people think how the community could help more. And I just obviously and there's a lot as well in response to some of the other questions that talk about how the community and the voluntary sector can help more. So my question really is around the voluntary sector and how you would be expecting to get those people on board to help with all the things that people are talking about in response to your questions about the community. Thank you.
So within mental health, one of the things that I suppose we're lucky with is we have a thriving voluntary sector community that want to work with us. What we also have is the mental health forum, where all these people come together. So we approach them, it's a mental health partnership, we call it, where we have both statutory and voluntary sector organisations come together, and when we're looking at developing models, we go to them with some input and to get ideas of expressions of interest, etc. for them. So if I use some of the crisis work that we're currently doing as an example, because this is how we will take the approach, we work up what we think is the scope in a very, if I say, high-level outline, so it's got the objectives and the aims that we want to achieve with it. We then take it back to the partnership to ask for their views on it, about how they may be able to support us to deliver it. Now, for the crisis one that we're currently doing, the partnership are coming together as a collaborative to develop that model and how that will be delivered on our behalf against the objectives that we've set. So that's how we will continue to work with the voluntary sector. We work very closely with Community Plus, and we always have done, in engaging with people, as well as the providers that we've already got within Kirklees. We've talked about the mental health contracts that are currently just being evaluated. Mental health is, I suppose, slightly further forward in how it's integrated over the years. It's one of the things that I think we do reasonably well. And we've had joint contracts in place with the third sector and with secondary sector providers for about 12 years now. This must be the 4th time that we've gone out collaboratively with contracts to the third sector, which helps us to ensure that they remain sustainable. But it also allows us to do the changes when they're needed. So if there's new direction of travel, national direction of travel, we can tweak those contracts and work with the providers to do that. So I think, touch wood, we've got the good relationships there to keep building on that and develop it even further to do this. As we've said, this is all about what we can do closer to people's own homes. So whether they're in supported tenancies, it's about what other services they can access to make their life more pleasant, more enjoyable, to start building up that resilience. I know some people need to be in services for a long time, 16 years, etc. But what we've also got are some people that's been the only option available to them, so they've become reliant on that, and we've not developed the skills to support people to find other ways of managing.
Sorry, I noticed that in some of the responses, one of the important things for many people was a continuity of the same person dealing with them. And obviously, if you're going to be replacing heavier reliance upon the voluntary sector, that may not happen, because it may be that people who volunteer may drop out at any stage. So I just wondered how that's going to work.
I think that's one of the views that we can take on board, that people would like the same people to remain involved. You get turnover in workforce wherever we are, whether it's a statutory service, a voluntary service, there is turnover. I think the element where we can help is by giving a degree of security and continuity in the contracts and the contract terms and lengths. So the contracts that are currently just being evaluated are for 3 years plus 2. So we're not talking that people are only going to get something for a year. We are looking at the continuity of that. And again, some of the providers that have bid again for services this time bid originally. So those providers do work closely together and carry on, even though the workforce may change. But you would hope it becomes in a planned way, that it's not so transient that people know somebody's leaving and start to be introduced to new workers. But that's the nature of the beast, really, isn't it? People do move on. We focus on peer support as well within that, so where people can get the peer support within, as well as the mainstay of the staff that retain.
Thank you.
So just to go back to something else that I think came up last time, and that's whether you've altered your commissioning arrangements for people with dual diagnosis. We became quite aware during the ad hoc report that when we were collecting the evidence, that there are a substantial number of people who have got either schizophrenia or bipolar, who self-medicate, either with, and the more we looked at it, we found quite a lot of them using opiates, And then, of course, the regulars that you see around town with Carlsberg aficionados. And when we kind of looked into this service, there was one very fractional contract for a psychiatrist, and the CPN was working with it, and that seemed to be it. And given that the rules were that you've got to be clean to get your psychosis treated properly, these people seem to be in a double bind. Thank you.
So it's not that they have to be clean, it's that they have to be stable and not in an unstable condition, so they can still be using as long as it's on a stabilised level. We do have a dual diagnosis service, as you've said. We have a specialist service, which is the consultant and the specialist CPN, who give the advice and support into the other. It's a bit like a hub and spoke model. So they're the specialists that outreach into some of the residential services that we've got, and then give the consultative support into mainstream mental health services. So we have that. We are looking at that. Now, interestingly, that's one of the areas that's been looked at a regional footprint as well. They've just done a mapping exercise, and Kirklees are one of the few CCGs that do have some service. So if you look just in our close vicinity, Calderdale and Wakefield, Wakefield have a limited service as well, but Calderdale don't have any service. So that's been looked at across the footprint as well to try and get everybody to a base level. But some of then the specialist inpatient facilities that may be required to get people to a maintenance position so that they can move back down the pathway are being looked at, like we say, at a regional level. The same as personality disorder services, inpatient personality disorder services are being looked at a regional level as opposed to us all developing an inpatient model. But we'll all have community models to support the pathways back or prevent people stepping up.
That's good, thank you, because it seemed when we looked at it that you needed 4 good A levels to really get treated.
Also, part of the problems was as well that third sector group organisations, voluntary organisations, were having problems connecting with the service and getting people referred into that service. And so, as part of your modelling, you need to take account of that.
Yeah, and one of the things that we actually had a meeting last week about some of the new stuff we're looking at is about not putting substance misuse or the use of street drugs as an exclusion criteria to services. What we're looking at is trying to build it in such a way that people can access the service, but then they get rapid assessment by a professional. So whether it's in the third sector, they'll get that rapid assessment to then what is it that they need over and above. If it's not safe to leave them in the service that they've gone to, then how we get them signposted and moved to the right service. But to try and eliminate that as an exclusion criteria. The same with psychosis, to be honest. We're also saying that psychosis won't be an exclusion criteria for some of the services. That it is an illness that people have got. They should be able to access services that we've got there, and we might have to put a slightly different wraparound to support them.
Thanks. Yeah, I've got a couple of questions. First one's on section 5, page 32 of our report. It's about out-of-area placements. So there's a map, and then there's a reference to there being 8 providers with 52 service users. So the first question is there an intention or an aim to do something about the number of outer area placements to allow the opportunity for more people to come and have provision within Kirklees? And the second question is just specifically on the engagement. There were no responses received from the out of area placements. Is it possible to do some specific work on that? Sorry, just got question mark, responses received. So it looked like there weren't any, but okay, thank you.
Sorry, I'll just answer that. The report's still in draft, so obviously we needed to send it in a timely manner to you, so we're just reviewing it ourselves. There was actually 28 responses, so thank you.
And yes, the whole premise of doing this piece of work is to try and get people located back within Kirklees, either because it's the right place for them, because they want to be back closer to family. We're not saying we will completely eradicate out-of-area placements, because there will be some people that it's the only option that we've got for a whole range of reasons, and I think we discussed some of those last time. What will be reviewed as well, though, is what is constituted as out of area, especially if we're doing more work on a regional footprint for some of those very small numbers of people. So will out of area become West Yorkshire, which is still a massive improvement from sending people up to Scotland and Wolverhampton and such like, yeah. But the aim is that we will have much more provision locally with a workforce to support people. So it is only in those extreme cases that we are resorting to out-of-area placements. And the national direction that I was talking about earlier, that's their drive as well, that we look at people being as close to home as possible, and it isn't the default to send people out of area.
And presumably the funding's already there, because the funding's paying for people wherever they are out of area.
Yeah, so that's what I was saying before. We've scoped all of that into it, so whatever we're spending out of area is potentially in that pot to develop new services.
Second question was on page 25. It's about where people get their support from, basically. So 33% from a care coordinator, 21% from a specialist team, and then a range of other sources of support. What I wasn't quite sure about was whether, to what extent, in terms of the people who'd responded, there'd be a requirement for them to have a care coordinator or a specialist service provider. So to what extent is this a concern that some people don't have either a care coordinator or a specialist service support team?
Okay, so that is dependent on the individual's presentation. So anybody who's accessing secondary care services or has been through secondary care services will have a care coordinator. People who have lived independently within the community get support either from GP practices or from the third sector, maybe occasionally have touched a CMHT. They won't necessarily have a care coordinator. And what we'll be looking at is about how we support people with signposting and having go-to points. So some of the information that we've gleaned from this and some of the work that we've been doing is looking at where we might develop telephone helplines to give people signposting. Now that, as an example, is one of the areas that we are discussing on a slightly wider footprint, so not just within Kirklees. Wakefield, Calderdale is where we started the discussion, and then we took it to the regional meeting 2 weeks ago to ask if on a regional footprint that might be something that's worth commissioning. Because if people are sat on a telephone and they're dialing a number, it doesn't really matter where they are, as long as what they've got is the full directory of services for each of the localities. They've got the experience to listen to people and then to signpost them as appropriate. So we're exploring those options as well.
Can I just add as well, we didn't limit the engagement to those who were using services at the minute. We wanted to explore wider audiences, so that might explain that statistic as well.
Any other questions on this engagement? Yeah, I've forgotten. You go first.
Just to say that I've been involved in the trust, mental health trust's personality disorder steering group that's looking at an innovative way actually of changing how we support people with that diagnosis. And I've also got a meeting this afternoon with the Mental Health Trust to look at dual diagnosis, because I often find those both of those categories present in the people with complex diagnoses and needs. And I just really wanted to make a positive comment to say that how pleased I am that the Trust is recognising that the support that was in place before wasn't working. And yet these are some of the most vulnerable people in our local community. And so we don't have a magic wand, but you know, I'm really heartened to recognise that we are moving in the right direction. And I think it's important to acknowledge that here. Thank you.
So can you just outline for us then how you're going to move this engagement into your modelling so that we understand, and your timeframes, please? Thank you.
So the write-up of the engagement will be finalised, and then what we've started doing, we've got a working group looking at all this information now, and what we're starting to do is plot what the different levels are that are required. So that goes from the hospital provision right through to supported living. What we're trying to do within that is put some numbers as well. So we know the people we've currently got in the system, but we're also looking back at some of the 3 years worth of data just to see what some patterns of behaviour have been, so we can build up some trend analysis within that, with a view that we can support then the development of the entire pathway the whole way through. So some things will be easier for us to do. So some of the work that we're doing with the voluntary sector has already started. We've already started doing some redesign within existing contracts, so with people like Richmond Fellowship, etc. We're redesigning or changing their specifications slightly so that they're capturing the right people. The other element that we are also looking at doing then is really scoping out what the specification for the hospital bed base and what the community team will need to look like, because that will be taken from the existing resource that's there, so we need to be able to identify how we can start that shift happening. The aim is that we will have all that completed by April time, so it's going into the planning now, with a view that then we start doing the mobilisation through next year. But like I say, we'll do it in phases, so some of it we're already on with and other bits will take the time.
Can I just add as well, obviously, if part of the modelling is significant service change, then we would need to consult the public on those plans as well. So we would go back through the networks that we've already been in contact with and throw the consultation out wider. So just to add that.
Yeah, I think as well that Scrutiny would like to take a view as well on whether it's significant or not. So are we content with the engagement so far? Yes. But we'd like to see your model and then to see how you translate this engagement into your model. It's clear that people want different levels of support in this, and what's come out again is the help and support and access to support before crisis and everything. So there's some quite clear messages that are coming out from this engagement, and we'd like to know what your model is, and then we would like to see, and then Scrutiny will take its own view as well on whether we feel any parts of it are significant as well. Can I just I realise your report's in draft, but on page 56 you've got BD11 as an out-of-area postcode. When I left home this morning, it wasn't in Kirklees.
Apologies for that.
So
that's noted. Yeah.
Can you just,
thank you.
Thank you very much. Okay, thank you. I was feeling out of area. Yeah. Okay, thank you very much for your report. Right then, and for the agenda, the work programme is as is. If there's any comments on that, no. And the date of the next meeting is the 15th of January. Thank you very much, everybody. Thank you.